First, congratulations to this European initiative. I think it's really super and a great move. And I think we as doctors are more than happy to support you on this way. And we hope it's just the beginning of a very long and successful road with regard to this event. So I'm the last preventing you from lunch. That's very difficult. So I was told to be fast. So let's see. Okay, so these are my disclosures. So just the first introductory slides, just want to give you the spirit that we are really living in a dramatically positive time. So we have really seen so much progress in B-cell lymphomas, in particular also in Waldenstrom's macroglobulinemia. So this is why you should go home and have really the feeling things are changing, and Simone will tell you then also about the new approaches we have and clinical trials we have. So I think that's very important. So it started, as you see, with this trial on Waldenstrom, 1943. So we have anniversary in September. It was submitted. So 80 years ago. So when we go one back, and you can still read it. So it's scanned in. You can read it, and you can see how Jan Waldenstrom really described this new syndrome, which was then later coined after his last name, Waldenstrom's macroglobulinemia. So we have seen a historical development. Chemotherapy is still important, but many decades actually, and this is shown here for follicular lymphoma, which is a related B-cell lymphoma, we had not made any progress. So we tried to modify chemotherapy, to change drugs, to intensify. What you see here, so this is a typical Kaplan-Meier curve, the survival of patients with follicular lymphoma in the different decades of clinical trials, and it was actually superimposable. It was very, very tough. And at that time, we had certain pillars of lymphoma treatment, so importantly chemo, but also radiation and surgery. But as said, we are now really moving into a completely new era where we see an acceleration of progress. And this is really dramatic. This just again show you a little bit of medical history, and with the emergence of small compounds. So the first one was imatinib or Gleevec for chronic myeloid leukemia. So we can really discriminate a pre-rituximab or pre-kinase inhibitor era where we didn't have these targeted treatments we have now. And then, of course, for us important, as a first-in-class compound, ibrutinib as a BTK inhibitor, again an anniversary. It's 10 years ago since it was approved for chronic lymphocytic leukemia, and 2 years later for Waldenstrom's macroglobulinemia. So we are in a completely different era now of targeted treatment, which also postulates to be chemo-free. And this is why I think it's so important to have the slides and to convince you that the future looks bright. So this small molecule really changed the world. So this is rituximab in a 3D animation, and it was the first proof that chemo-free targeted treatment works in B-cell lymphomas. So where are we now? So current treatment landscape, where are we standing? So we have more pillars of lymphoma treatment. You see now on the right side, we have the antibodies, we have the small molecules such as the BTK inhibitors, and we have now immunomodulation, or you could now substitute it for immune therapy. It's not the topic today. I don't know whether Simone will mention it. It's a little bit early, but the Dutch team is actually planning such a first trial, very important trial. So we have the bispecific antibodies and the CAR T cells, and we are sure that they also will play later on a role in Waldenstrom. So clearly the trend is away from chemotherapy. It's because it's thought to be like a bulldozer treatment, and non-specific. The trend goes away from intravenous, sub-Q, or oral treatment, very sure. And of course, we are very happy that we, move forward to the vision to have a magic pill. So there is still no magic pill. I remember when I was first invited to the board of a small company which produced ibrutinib, they told me, Waldenstrom is solved. It's not like this, but for sure we have made a major step forward. So what about treatment? How does it look like? And you see that still old traditional rituximab chemotherapy plays a role. So these are the ESMO guidelines 2018. We are responsible for, so many colleagues from the European Consortium are responsible for. We will update them next year. So we got the green light from ESMO, and they will be produced together with EHA. So it will be really a big community standing behind these guidelines. And what you see here is what you do in symptomatic Waldenstrom several years ago. So it's from 2018. And as illustrated here, you see that immunochemotherapy, which is DRC, bendamustine, rituximab, is still very dominating, but that already at that time, ibrutinib was one of the recommended options for first-line treatment of Waldenstrom. So we have now updated the German, Austrian, Swiss guidelines for Waldenstrom, and you see that something changed, and we will, as I said, transfer this to the ESMO-EHA guidelines because BTK inhibitors have become more dominating. So this is again first line. You see when you are asymptomatic, you do watch and wait still. It's the standard approach when you are symptomatic, and then of course it depends a little bit on your fitness. You use rituximab chemotherapy, or you can use ibrutinib rituximab, or zanubrutinib single agent, or ibrutinib single agent. In Europe, it's a little bit strange because it's a situation in Germany, ibrutinib single agent or zanubrutinib single agent is only reimbursed and paid when your patient is not tolerating chemotherapy. So strangely, when you add rituximab to ibrutinib, it's reimbursed for all the patients with Waldenstrom. So this is the situation in Europe based on certain data, which I show you in a second. So this means rituximab chemotherapy is still a very important backbone of treatment because it has advantages. It's fixed duration, so it's, for a fixed duration, it's not a continuous treatment such as BTK inhibitors, and it's active and well tolerated. So there are two regimens which are recommended internationally, and one is rituximab bendamustine, and the other one is CDR, we call it DRC, which is a combination of dexacyclo and rituximab. So with these two regimens, you can achieve quite a lot of efficacy, and normally these regimens are well tolerated. So this is a trial from the European Consortium, which was designed before ibrutinib was introduced, and it's now the largest data set, prospective data set from recent times we have for patients with Waldenstrom treated with chemotherapy first line. And it shows you that actually this very mild immunochemotherapy is highly effective. So this was a trial in first-line Waldenstrom patients, so treatment naive, in need of treatment, and we randomized at that time these patients 1-to-1 into DRC, which is this normal dexa rituximab cyclo, it's a mild immunochemotherapy. We de-escalated this regimen, so we gave it every 4 weeks, not every 3 weeks, so even softer than the originally published regimen. And in the experimental arm, let's call it like this, we added bortezomib. So these are the key takeaways from the study. So what we saw was actually that DRC, and bortezomib DRC a little bit more even, is highly effective in getting you into responses. So the vast majority of patients actually achieved a response. And what we also saw that we can achieve deep remissions, which is VGPR for the experts, or deep remissions in every 5th patient with DRC and in every 3rd patient with bortezomib DRC. So it's highly effective. What we also saw was that the progression-free survival at 2 years can compete with ibrutinib, not later because you stop treatment, but at 2 years around 70 with DRC, or 80% of the patients are still progression-free, which means that this trial, which will go into a final analysis where we can say a little bit more about the progression-free survival, means that it demonstrates that our chemo is still a very valid option, and that the quotation of these treatment tools in our guidelines and also in the ESMO EHA guidelines later on is justified. So there's always a big question about rituximab maintenance in first line when you have given chemo, because this is one of the standards we are using in follicular lymphoma, as I said, related B-cell lymphoma. This is a very important trial from the German Steel group. So they treated patients with bendamustine rituximab and patients who actually responded, and this was over 90% of the cases true. They were randomized between just watch and wait and rituximab maintenance for 2 years. So these are actually the primary endpoint of the study. So the hypothesis was that with rituximab maintenance, you improve progression-free survival. Again, this is like a Kaplan-Meier plot. You see the curve, and every step is a patient who has progression, and you see the comparison between observation in red and rituximab maintenance in blue. So there was no difference. We are not recommending rituximab maintenance first line outside of clinical trials for the Waldenstrom patients. There might be some situations where you can discuss this, but in generally not. So this is the key takeaway. Rituximab maintenance does not delay progression compared to watch and wait. And in clinical routine, rituximab maintenance is not considered to be standard treatment. So rituximab chemo, as I said, it's very important, but for sure BTK inhibitors now set the standard and has dramatically changed the treatment landscape. And this was the trial which actually led to the approval of ibrutinib, a smaller trial by Steve Trion in Boston. Ibrutinib, non-fixed duration, so it's a continuous treatment here in the relapse refractory setting. And you see now the response rates. And at that time, before the introduction of zanubrutinib, this was the most powerful single agent we had for Waldenstrom. So overall response rate is around 90%, and major response rate means partial response or better, so 50% or more. It's 70%. So these were actually great data. But we learned that there are challenges with ibrutinib because we have these two mutations. MYD88, 95-97% of all patients, like a genetic hallmark of Waldenstrom, and we have the CXCR4 mutations, around 40%. So these two highly recurrent mutations. And this has implications because we can form genotypes, so groups of patients, depending whether this MYD88 gene is altered or not. And you see we have three groups: patients who have only the MYD88 mutated, patients who have both genes mutated, and patients who do not have MYD88 mutated and CXCR4 mutated. So when you now go for ibrutinib, single agent, and you look at the response rate, I don't know whether I have a pointer here. Oh, okay, super. The major response goes really down when you have CXCR4 mutation or MYD88 wild-type constellation. So there is like a gradient of responsiveness towards ibrutinib depending on the genotype. So it's clear-cut clinical implications. And this is also seen with the progression-free survival. You see here the most sensitive population, the CXCR4 mutated, and the MYD88 wild-type patients. So it's a problem. So we have to see how we can improve ibrutinib. Yeah, any ideas to overcome? The first idea we had is to add rituximab to ibrutinib. And this was the INNOVATE trial, which again took Waldenstrom patients in need of treatment, mostly relapsed, and you had a 1-to-1 randomization between ibrutinib plus rituximab versus placebo rituximab. So what were the results of this study? Ibrutinib rituximab is more effective than rituximab alone. I think this was not a surprise, but important because based on these data, ibrutinib rituximab is available in Europe, as I said, for all Waldenstrom patients, first line as well as in relapse. But what we also saw was when you have a CXCR4 mutation, both genes are mutated, it works actually as good as CXCR4 would be not mutated. So clearly different to ibrutinib single agent, and of course it was feasible, it was well tolerated. So this is just the background that you know why we are using ibrutinib rituximab, and this is one treatment option for CXCR4 mutated patients or MYD88 wild-type patients. But we have now zanubrutinib as a second-generation BTK inhibitor, which is as good as ibrutinib rituximab, and of course it's easier to give. So this is, shown here. It's progression-free survival, and you see here that actually the PFS, the progression-free survival, is very similar between the 3 different groups. So this, for us, was the most striking result of this study. So, as I said, any ideas to overcome the limitations of ibrutinib is to just develop better BTK inhibitors. Yeah, and so we are very happy that we have these. And this is a trial which actually established zanubrutinib as treatment option for Waldenstrom. So based on these data, zanubrutinib is approved as single agent, first line when your patient is not so fit, and for all patients in relapse. So the trial also very simple. Waldenstrom patients, mostly relapsed, but also treatment naive. You have here first one cohort, so they are all MYD88 mutated, and they were randomized between zanubrutinib and ibrutinib. So it's really a head-to-head comparison. And there was a small observational study for patients who had MYD88 wild type, so 28 patients, and they only got zanubrutinib with the idea that ibrutinib is not working in this patient population. We had a major response rate of 0% with ibrutinib. So let's see. So what were the results? So first, zanubrutinib is more powerful than ibrutinib in inducing these deep responses. So over time, you can achieve deep responses in a little bit more than every 3rd patient. But it needs time, yeah, but you get this proportion of patients. Just to remind you, bortezomib DRC is more or less the same, and it's a treatment for 6 months. So there was no difference in the time to progression or overall survival when you compare zanubrutinib with ibrutinib. But what is clinically highly relevant, zanubrutinib was much better tolerated. So, and this is important for us in daily clinical life. So we have less cardiac toxicity, you have less impact on hypertension, for instance. So that when you take it together, it's a very attractive drug. Deeper responses, better tolerated, it's a single agent drug. So it's really very attractive when you compare it to ibrutinib or even the combination ibrutinib plus rituximab. And you remember there was this small cohort of MYD88 wild type, non-mutated patients. Very few, 2-3 Waldenstrom patients per 100 Waldenstrom patients. But with ibrutinib, no chance. But the study showed that when you use zanubrutinib, you get over 60% of patients into a major response. So it's clearly different, and it's a very good alternative treatment beside our chemo in these patients. So this just shows you again the side effect profile. So this is, cardiac toxicity, hypertension, and it's a class effect. It's not that zanubrutinib is not causing this at all. This is red, but when you see more patients develop atrial fibrillation or flutter with ibrutinib compared to zanubrutinib. So what about treatment now? Relapse, we have touched this already. This looks terribly complicated, but it's not. Yeah, this is just the duration of remission, the duration of response you had with regard to first line. So forget all this and just focus here. And it's very simple. What you have is, again, our chemo in theory, or you have the BTK inhibitors. And practically in daily life, the BTK inhibitors are clearly dominating when we manage relapsed patients here in Europe. So first line, the summary, timing, do not harm, only start treatment if you need to. So this watch and wait strategy is absolutely still valid, even in this new era of fantastic new drugs. Then choose between rituximab chemotherapy or BTK inhibitors when you have to start treatment. And of course, we will hear a talk about this. Waldenstrom has made progress because of clinical trials, so we always would encourage patients to go into clinical trials. It's a rare disease. Relapse, so when you have a relapse, it's the same. Again, watch and wait. So when you have progression, it does not mean that you need treatment. So we measure progression-free survival and time to next treatment. These are two different parameters, and they might be very different. So when you have a progression, it might be that you again enter into a new watch and wait period, which can take very long. And you see here it's very similar, but clearly now dominating the BTK inhibitors, and of course, clinical trials being important here. So the questions, where are we going? What are the key challenges? I think one of the big topics at the moment is that the BTK inhibitors are great, but nobody likes them to take them forever. So we have to find ideas how we can use these BTK inhibitors, but for a fixed duration time period, let's say for 1 year, for 2 years, and then being able to stop. I think Simone will talk about this, but yeah, so this is my last slide. Again, I think we have made tremendous progress, and Simone will tell you that it's really continuing. And thanks a lot, and I'm open for question.